Hello, listeners. We want to let you know that we will be presenting at the Pennsylvania Society of Addiction Medicine annual meeting online on March 2nd. You can hear us speak and even see what we look like.
After an extensively heated discussion, Sonya and I have picked the 10 articles that we reviewed which changed our practice the most.
It's a little embarrassing, but we're going to put ourselves out there and tell you some of the things that we did wrong and how we changed our ways after reading these 10 articles.
You can register for the conference at psam-asam.org.
Hope to see you all there.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. How are you doing today, Sonya?
Doing really well. How are you doing, John?
Good. I'm kind of recovering from a man cold right now, but otherwise I'm doing well.
How does your wife think you're doing?
Hospice status.
Yeah. Good luck.
I feel like there's nothing worse than not feeling well, like muscling through a clinic of 30 patients. But
right.
I did it 2 days this week and I'm feeling better. So ready to roll with some articles tonight.
Well, that's great because this is a special episode. We went back through our archives and we looked at all the articles we reviewed and chose the 10 that have made the biggest impact on our practices. And we want to share that with all of the listeners of the podcast. We also are going to be a little vulnerable and we're going to tell you what we used to do before we read those articles, some things we might have gotten wrong and how we might have managed our cases less than an ideal manner. And now that we know more, how we have changed our practices. And this is part 1 of 2. So we're going to cover 5 articles on this episode and we'll cover 5 articles on the next episode.
All right, so I'm going to get started with my first one. So this is a real patient that I saw in my office. This is a 65-year-old woman with a history of COPD, coronary artery disease, hypertension, atrial fibrillation, and anxiety, who presents with a 4-week history of cough. She was previously treated with a Z-Pak at urgent care, and now she's here for follow-up due to lack of improvement. An X-ray reveals a concerning area in the right upper lung, possible atelectasis consolidation or a lesion. A CT scan confirms a 2.3 centimeter mass in the right upper lung, suspicious for cancer with associated enlarged lymph nodes. Biopsy confirms adenocarcinoma, and a PET scan shows active cancer in the lungs and lymph nodes, diagnosis stage 3A, lung adenocarcinoma. So what I used to do in this case, I would discuss goals of care and refer the patient to oncology. Regarding smoking cessation, however, I typically would suggest that at this stage, quitting would likely have minimal impact. Therefore, if the patient wishes to continue smoking, they are free to do so, sort of like a palliative intervention.
Yeah, and it's interesting, John. I think as we do lung cancer screening, now more and more, we see this kind of situation more. We're diagnosing lung cancer earlier and more often. So we see a lot of patients with lung cancer diagnosis in primary care now.
Yeah, definitely. The article that I read that kind of changed my practice is called Post-Diagnosis Smoking Cessation and Reduced Risk for Lung Cancer Progression and Mortality. It's a prospective cohort study from the Annals of Internal Medicine from 2021. The clinical question is, does smoking cessation affect mortality and disease progression in current smokers diagnosed with early non-small cell lung cancer? And they define that as stage 1, 2, and 3A. The study design was a large, multicentric, prospective cohort study of patients with newly diagnosed stage 1, 2, and 3A non-small cell lung cancer who were recruited between May 2007 and July 2016 from the Department of Thoracic Surgery at NN Blokin National Research Center of Oncology and City Clinical Oncological Hospital in Moscow, Russia. They did annual follow-up occurred to assess vital status, tumor progression, events occurring after diagnosis, therapeutic procedures that had occurred, and whether they continued to smoke if applicable. I really liked the study because the cohort was actually linked to both a national cancer registry, but also a national death registry. So it really had a lot of good data collected in it in terms of survival and outcomes for these patients. The results were pretty substantial here. So to kind of go through it all, patients who continued to smoke had higher all-cause mortality. Patients who continued to smoke had higher disease progression. Patients who continued to smoke had higher lung cancer-specific mortality. Patients who continued to smoke had a lower adjusted estimate of overall survival. Patients who continued to smoke had a lower adjusted estimate of progression free survival, and patients who continued to smoke had a lower adjusted estimate of lung cancer specific mortality compared to those who quit. So, and when you actually look at kind of the median time for the lung cancer specific mortality, the difference was 6 to 7.9 years, and all of these results were highly statistically significant. Returning to this case, this does definitely kind of change how I do my practice. I kind of scratched the entire second part of my spiel now. So while I think that this still starts with the goals of care discussion, especially a patient with medical comorbidities, whether they choose to go through with palliative or curative intent treatment, I also will then transition over to a period where I talk about tobacco cessation, noting that, regardless of whether this is a curable condition, that even quitting smoking at this point could extend survival. And in this study, it was up to about 2 years. It was actually 21.6 months of adjusted median overall survival. So 2 years is a lot of time. So definitely something that now I've kind of incorporated into my non-curative lung cancer spiels.
Well, and 2 years of additional life is more than you would get from a lot of our chemotherapies or other interventions for lung cancer. Yeah, I've totally changed my practice too. I now definitely counsel smoking cessation, even for patients at end of life. And I was thinking about this today, actually. I have a patient, different situation, but severe COPD. He had been kind of end stage. We had placed him on hospice. And after many, many decades of tobacco use, he quit smoking. In that process, he just couldn't stand smoking anymore, and he got so much better that he graduated from hospice. It's been 8 or 9 months since that time when he quit smoking, and about 10 months since I thought that this was the end. He's just renewed his driver's license, he's getting out of the house a little bit, he's moving to a new place that's more handicapped accessible and sort of preparing to live whatever of his life he has left, which is a lot longer than we predicted. And he's so much better clinically since he quit smoking, even though he was very, very ill. So I do believe that quitting smoking can help you out. And I completely counsel it to patients, even if they have metastatic lung cancer.
Yeah, interestingly, the patient in this case, I diagnosed this patient with lung cancer, I think my first year as an attending physician, and she's still with me kicking strong 6 years later. So she quit smoking at her diagnosis. So it was amazing. Really
Oh,
proud of how she did.
congratulations to her. That's amazing. All right. Next article. So here's my case. This is a 26-year-old man. He tells you he thinks he has a problem with alcohol. He gets completely drunk. He's not sure how many he drinks when he goes out with friends on the weekends, and he's found himself in sexual situations he regrets the following day. He also has some blackouts where he doesn't remember what happened after a night of heavy alcohol use. He drinks daily as well as those binges. He drinks 4 to 6 beers every night after coming home from work, and he feels pretty tired and sluggish. So, what I used to do for someone in this situation who wanted to cut down on drinking, I would offer naltrexone injections or daily oral naltrexone. It might give you some headaches, it might make you nauseous, or you could come into the doctor every month for the shots. How does that sound? Let's try those things. And patients didn't really take me up on it. So the article I read that changed my practice was called Targeted Oral Naltrexone for Mild to Moderate Alcohol Use Disorder among Sexual and Gender Minority Men. And it was a randomized trial about targeted naltrexone. For those of you who might not know that term, targeted naltrexone means naltrexone that you take just when you feel alcohol cravings or you anticipate binge drinking. So maybe you would take it on Saturday afternoon before going out at night, or you might take it if you feel a craving or right before you have dinner with your mother in law who drives you crazy. That's when you would take your naltrexone, but you don't have to take it every day. And so the clinical question here was, does taking this targeted naltrexone when you feel alcohol cravings or anticipate binge drinking lead to reduced alcohol use? So, John, before we read this paper, had you ever used targeted naltrexone?
I've read about the concept. I've never read any studies about it, though. I think I just saw a blurb about it, like opinion from Up to Date. But it's not something I routinely did. And to be kind of 100% transparent for alcohol, I typically really push the IM injection, just knowing that compliance tends to be an issue with the medication.
Yeah, me too, as well. So, this was a randomized study, placebo controlled, blinded trial. It included 120 adult men with mild to moderate alcohol use disorder who have anal intercourse with men while under the influence of alcohol. So, men engaging in risky sexual behavior while under the influence, and men who binge drank at least once a week. So again, 120 men, and they were given either 50 milligrams of naltrexone or a placebo pill, and they could take it during periods of cravings or when binge drinking was anticipated, and they were followed for 12 weeks. They self-reported their alcohol use, and they did get some alcohol biomarkers measured, as well as secondary outcomes of risky sexual behavior, alcohol cravings, and patient satisfaction. So targeted naltrexone had some significant effects here. So what did it do? So to prevent binge drinking, like a binge drinking day per week, the number needed to treat was 2, was very low. So naltrexone really cut down at least one binge drinking day in 1 out of every 2 people who took the targeted naltrexone. The number needed to treat was 7.4 to prevent binge drinking for an entire week. And number needed to treat was 5.7 to prevent 10 additional drinks per month. So decreasing overall alcohol use. So its strongest effect was in decreasing these binge drinking days. So what did it not do? It didn't reduce the total number of drinking days. So people still drank on the same number of days. They just drank less and didn't binge. It didn't reduce the presence of alcohol biomarkers. So again, people continue to drink. And it did not reduce risky sexual behavior. So these people in the study continued to engage in sexual behavior while under the influence. The other thing that was interesting was that at 6 months, the naltrexone group had a persistent decreased alcohol use. So even 6 months later, once the trial was done and they were no longer taking the study medication, they had fewer drinks in the past month, fewer binge drinking days in the past week, and less binge drinking overall. So another thing that was cool about this targeted naltrexone, like you said earlier, people didn't necessarily tolerate the oral naltrexone. It can have side effects and they just didn't take it. It doesn't work if you don't take it. But this way, you don't have to take it every day. You could take it only on the weekends, say. And so patients reported taking the study medicine on average 2.5 times a week. So 2 out of 7 days they would take the medicine, 2 to 3 out of 7 days. And it was 74% of the days they craved alcohol or anticipated heavy drinking. 84% were satisfied with the experience, and there was minimal reported adverse effects. So the patients really tolerated this well and stuck with it in a way that we don't see in clinical practice when you're taking daily naltrexone. So after reading this, I really could conclude that targeted naltrexone, 50 milligrams, taken at times of alcohol craving or anticipated binge drinking, reduced alcohol use and binge drinking without impacting the total number of drinking days. So now instead of offering daily naltrexone or naltrexone injections, I won't say instead of, but in addition to, I offer patients a choice of targeted naltrexone. So I might say to my 26-year-old binge drinker and daily drinker, there's a way for you to really cut down on your drinking. You could take naltrexone just when you have cravings or on days when you know it will be hard to resist alcohol, but you don't have to take it every day. And it will definitely help. It'll reduce that binge drinking, even if you just take it when you think it's going to be a heavy drinking day.
I really like this approach. I think that a lot of these kind of high risk behaviors for most patients and most people, it's not like an everyday thing, right? So I think it's sometimes tough for people to want to take a pill, want to take an injection, want to take something every day of their life. However, I think they do want to mitigate their risk. And I think targeting towards periods of time when they feel they're at risk, I think increases compliance and engagement. I know that there's a similar thing now with targeted PrEP. One of the 2 products was recently FDA approved for that. And I think it ends up having a lot more uptake because people just use it when they feel they're in a period of risk.
Yeah, no, I agree. It gives patients more control over the process. It minimizes side effects. And a lot of people really have used this method and like it.
Case 3. A 24-year-old female with a history of opioid use disorder, PTSD, generalized anxiety disorder, and tobacco use disorder comes in concerned about a missed period. She's been stable on 16 milligrams daily of buprenorphine naloxone for 23 months. Worried after her friend's advice, who is also on buprenorphine, she's been told to switch to buprenorphine alone due to a potential harm to a baby. A urine pregnancy test in the office is positive. What I used to do. So I used to notify the patient that we'll be again transitioning her over to buprenorphine alone and discontinuing the naloxone component, aligning with it what is considered standard of care, although evidence behind that is somewhat minimal. I would anticipate a 24 to 96 hour period of communication with her insurance, culminating in the patient receiving the product, albeit with some anxiety. And this was like a real destabilizer a lot of times. I think people were so like perception so high that the combination product is actually like teratogenic or harmful. And so at times people would just not take the medicine at all. They would be going through withdrawal, very high anxiety levels. I read this article called Buprenorphine Naloxone versus Buprenorphine for Treatment of Opioid Use Disorder in Pregnancy. It was from the Journal of Addiction Medicine in 2022. Do you encounter this often?
I have, and when I started prescribing buprenorphine, I would always switch patients over to that mono product, the buprenorphine alone, and the first patient I had whose baby is now, I think, 6 years old, was actually referred to me from another provider. The patient had just extreme vomiting on the buprenorphine alone, and the buprenorphine naloxone combo, for whatever reason, was tolerable to her. She really wanted to stay on it and not switch, and the provider she was seeing was uncomfortable doing that, and I guess she thought I was kind of like a renegade, so she just referred the patient to me to do the buprenorphine naloxone, and that was my first patient who stayed on that in pregnancy, and as I said, that was about 7 years ago, and since that time, I researched it, and I really was not convinced by the evidence that it was necessary to switch people, so since that time, I've been more comfortable with just doing buprenorphine naloxone if the patient wants it.
Yeah, I remember early in my career when I was like a young, bright-eyed attending, and you were my senior here in this domain. I remember a very riveting opioid lecture where you and one of our MFM doctors had a very heated back and forth discussion about this topic, and so I know you're very passionate about it.
Yes, we did go head to head in public, but he was very gracious about my public criticism of him, and we get along great, so.
Sure, sure. So, clinical question. One, is there a difference in return to opioid use in pregnancy between birthing persons treated with buprenorphine naloxone compared to buprenorphine? And two, is there a difference in need for pharmacological treatment of neonatal opioid withdrawal syndrome in infants born to birthing persons treated with buprenorphine naloxone compared to buprenorphine? The study design. So, this was a single center retrospective cohort study of deliveries at Boston University Medical Campus / Boston Medical Center from 2016 to 2020. To give you a little bit of background as to what was going on at that institution during this time frame, in June 2018, BMC transitioned to buprenorphine naloxone combination for all pregnant patients with opioid use disorder. So they like basically abandoned the mono product altogether for these patients. In October 2017, they also transitioned to treating NOWs with a fixed to a symptom triggered protocol. So they went from like a fixed dose taper to symptom triggered, similar to how a lot of our alcohol withdrawal protocols have kind of changed. Retrospective data was collected for both birthing persons and neonates from the EMR. Birthing person data was illicit drug use, gestational age at enrollment, buprenorphine dose at initiation, number of OB visits, number of prenatal visits, number of UDSs, number of returns to opioid use, gestational age at delivery, buprenorphine dose at delivery, mode of delivery, and breastfeeding status. Neonate data included birth weight, head circumference, APGAR scores, NICU admission status, and NOWS outcomes. So those are all like really patient-centric outcomes. I really kind of like that about this. Results, like spoiler alert, there's no difference between the two.
Mhm.
So there's no difference in return to opioid use. You know, in the mono therapy group, 23% of patients return to use compared to in the combination buprenorphine and naloxone group, 26%. There was no difference in prenatal and delivery characteristics. So they had statistically non-significant differences in buprenorphine dose at initiation or delivery, gestational age and enrollment, number of OB or prenatal visits they attended, gestational age at delivery, timing and mode of delivery were non-statistically significant in terms of their difference. So no difference between the two groups. There's no difference in neonatal outcomes. They had similar birth weights, head circumferences, APGARs. They received similar amounts of pharmacotherapy for NOWs. Their length of hospital stay was similar, and their NICU admission status was also similar. Kind of returning to this case, this kind of really changed like how I approach this entire situation. I feel like it's not nearly as stressful for me as it once was. So now I reassure the patient that neither she or her baby are at risk whatsoever. You know, I do understand that pregnancy, just like parenthood, it's very anxiety producing. If the patient does feel that they would be more comfortable switching to the monotherapy product, like they are just so concerned about it, I will accommodate them just because I want to support them through the pregnancy. However, until the new medication is actually in hand, I will tell them to continue their current treatment until the new medicine has actually been dispensed to them with no risk to the baby.
Yeah, agreed. I mean, I do the same thing now. I really let patients choose whichever form they want, and some people wanna switch and some people don't, and I say it's whichever you prefer.
Yeah, so that's really kind of a useful little tidbit for all of us to take care of pregnant ladies.
All right, another article. So this is a patient and, because I'm an internist, this is a very typical patient for me. So, a lady who's 68 years old with hypertension and high cholesterol during her Medicare annual wellness exam tells me that she has 2 glasses of red wine every night because it's good for her heart. And she has been doing this since 1993 when she saw a TV program about how red wine is good for your heart from the Harvard School of Public Health. So, what I used to say is, great job. Alcohol is good for your heart. But for women, it's healthier to have no more than one drink a day. So maybe cut down that 2 glasses of red wine to 1 glass of red wine. So that's what I used to tell people. And then I read an article that was association of habitual alcohol intake with risk of cardiovascular disease that was published in JAMA Network Open in March 2022. So, John, have you ever told a patient in the past that alcohol is good for their heart?
I think I was kind of maybe ahead of this article a bit. I think I had a old cardiologist in residency that, I one time said that comment to him like offhanded, and he kind of like stopped and looked at me. He goes, "Well, if you're going to use it as a drug, then you need to take it as a drug. So that means you're taking 2 glasses of wine every day and just 2 glasses of wine." He's like, "How many people do you know do that?" And I was like, "Well, okay, fair enough. I'll stop pushing that." And I think that kind of the way he phrased that and his look of disdain at me, I was like, okay, I'm just going to drop that moving forward.
Yeah, it's amazing these moments that our mentors or our attendings in training can have on us forever.
Yeah.
So, the clinical question in this study was, what is the association between alcohol consumption and cardiovascular disease? And this study used a unique technique called Mendelian randomization. And because, as you might guess, that it's a little difficult to do a randomized controlled trial of alcohol use and cardiovascular disease. You would have to randomize people at, age 21 or whatever to a lifetime of alcohol use and then some other people to no alcohol use and monitor cardiovascular disease rates over multiple years. That study just isn't going to happen. And so they used this Mendelian randomization as a proxy for a randomized controlled trial since genetic variants associated with alcohol use are randomly assigned to you at conception. If you remember Mendel and his green and yellow peas, you could get one or the other of the genes from your parents. And that's random. So it's kind of like a randomization to a tendency to drink alcohol or not. They used this genetic predisposition for alcohol intake as a proxy for actual alcohol intake. And the association is pretty strong. If you have the genetic predisposition, you are very likely to drink alcohol. And the researchers developed and validated then with real data a genetic proxy score, and they used audit C data from their participants in their database. So this study was done out of a genetic database in the UK called the UK Biobank, and it had 371,000 plus people in it, so huge data set. The people in this data set had pretty high alcohol consumption. The mean alcohol consumption was 11 drinks per week. And they looked at cardiovascular disease rates and that the specific diseases were hypertension, coronary artery disease, myocardial infarction, stroke, congestive heart failure, and AFib. They looked at those diseases in people who had the gene for alcohol and those who did not. And that was, in their mind, equivalent to people who did drink and people who did not drink. And they examined multiple possible confounding lifestyle factors as well to see if those would play a part. And so you can't see it on the podcast, but I definitely encourage people to look at the original article. If you remember from med school or residency, if you're an older person or an older doctor, we always talked about the J shaped curve of alcohol consumption. Your cardiovascular risk was somewhat higher at 0 drinks per week than it was at 1 to 2 drinks per week. So the curve started up and then it went down and then it started to go up again, making a J at more than 2 drinks per week. But this study actually showed a more exponential relationship between cardiovascular disease and drinks. So the lowest rate of cardiovascular disease was at 0 drinks, and it went up from there. There was no point and no level of alcohol use that was better than zero alcohol use. They also found that the reported cardioprotective effects of light drinking or moderate drinking that have been found in other studies are probably the product of confounding lifestyle factors. And when they adjusted for those factors, that basically attenuated the protective association between modest alcohol intake and cardiovascular risk. They also did find, though, and this is hope for those of you who do like to drink a little bit of alcohol, that light alcohol consumption, like one drink per day, was associated with a pretty minimal risk increase. And above that, the risk began to increase exponentially. So basically, there was no amount of alcohol that was good for your heart. So I tried to do a few calculations to see, like, what is the true number needed to harm? So the number of patients who would need to give up alcohol to prevent a case of cardiovascular disease. And for some of them, they're pretty high. So for hypertension, which is the most common of the cardiovascular diseases studied, about 16 people would have to give up drinking to prevent a case of hypertension. So to me, it seems reasonable that if you have a patient with hypertension, I would counsel all of them to give up alcohol as a potential treatment for hypertension. But for less common heart diseases like congestive heart failure or stroke or AFib, between 100 and 300 people, for these different diseases have to give up alcohol to prevent a case of disease. So the specific numbers aren't important, but I just want to emphasize that it's not a slam dunk. You don't have to tell your patients that they're definitely going to get heart disease if they continue to drink alcohol. It merely is yet one more risk factor towards heart disease, along with, sedentary lifestyle, high cholesterol, hypertension, tobacco use, your genes, all of these things that come together. So if we go back to my case, the clinical conclusion of this study is that no amount of alcohol is associated with improved cardiovascular health. And after about 7 drinks per week, that's when the risks increase substantially. So now I would tell my 68-year-old lady with high blood pressure and hyperlipidemia and 2 glasses of red wine every night that no amount of alcohol is good for your health. 1 drink a day is probably not too bad for you, but it's not going to make your heart healthier. And given your other risk factors, I would recommend avoiding alcohol altogether. And I would say, has she ever tried a mocktail? There are some lovely non alcoholic beverages you could enjoy instead.
Yeah, I think I definitely agree with this. I'm currently taking a class on healthcare quality. And one of the things that really struck me was they were talking about how millennials and Generation Z, our life expectancy is actually dropping compared to baby boomers. I'm not sure if you've heard that or seen that data. And it's attributed to what they call the four horsemen of the health apocalypse. It's like four items. And you know what it is? It surprised me. It's opioids, alcohol, depression, and suicide. And I was appalled by that.
Hmm.
And especially like opioids, yeah, people are, no one kind of agrees to a moderate amount. But the more that kind of patients talk to me about their alcohol consumption, a lot of people don't necessarily have a problem, but they're not happy with the amount they consume and kind of do identify that it's probably not a healthy habit.
Mhm.
So I don't know. I think I've started to kind of refocus in on kind of alcohol intake with a lot of my preventive care.
Yeah, me too. I mean, I always ask during my annual exams, do you drink alcohol? How much alcohol? What situations do you drink in? And I've become much more firm or kind of definitive about how it's a health risk and doesn't serve you well, especially, I deal mostly with older people and I don't really see them, they really do need to manage their risk factors as their risks go up as they get older.
Okay, so last case. This is a 28-year-old with generalized anxiety disorder and opioid use disorder. Stable on 12 milligrams of buprenorphine naloxone. They call to reschedule his appointment an hour before, citing a job interview at Starbucks. He'll need a 1 week bridge script to get him to an appointment next week. This follows a previous reschedule 3 weeks ago for a job interview at Amazon. So what I used to do is this used to kind of annoy me. I'll be kind of very transparent, and maybe I don't sound like a good doctor here, but I would grumble as I call it a 1 week bridge script to cover the patient till the next appointment. Normally at the next visit, we'd have a talk where I would kind of give them this spiel about the early stages of recovery and stress the importance that they need to prioritize their treatment in order to get the rest of their life in order. Then I read this article. It's called Sorting Through Life, Evaluating Patient Reported Measures of Success in Medications for Opioid Use Disorder Treatment Programs. And it's from Substance Abuse Treatment Prevention and Policy from January 2023. Do you ever have scenarios like that, Sonia?
Oh, all the time, because I think our patients have somewhat unstable lives and getting to appointments is difficult and they really are trying. But between job interviews, childcare issues, court dates, there's all these reasons they might miss their visits. And I used to kind of parrot a little bit what some of my recovery specialists would say, things like, "Your recovery needs to be your top priority. If you need to skip out on all these other life activities to focus on your recovery, you need to do that." And I sort of went along with that, but then we read this article and we learned some new things.
Yeah, I think I got to give my office a lot of credit. I think like I'm certainly the contrarian. I think sometimes in the office where I pick up these niches that the other docs don't really kind of embrace, and it's a big culture shock because like my MOUD clinic is just it's chaotic, right? People show up when they show up. Some are 2 hours early, some are 3 hours late, and like that was a big change to get people just to kind of roll with it. And they've really embraced that over the years. But you're right. There's just so much chaos that people are trying to fight through. Like just showing up to the clinic at all, even an hour late, it's big for them.
Yeah, agreed.
So the clinical question here is what is the priority of participant driven measures of success in medication for opioid use disorder treatment? So, I'm going to start off by saying this is a pretty small study and it's not our typical study, it's a qualitative study, but like this one really impacted me personally quite a bit. So, it's a secondary analysis performed of 16 qualitative interviews of participants 18 and above in medication for opioid use disorder treatment programs. It's a qualitative study with two arms of data collection. The first arm, they did identification of items for a pile sorting task. And they did this through a semi structured interview and qualitative data analysis. A qualitative interview was performed, and domains of interest were assessed to include previous experience with medications for opioid use disorder, motivation for treatment, personal goals with medication for opioid use disorder treatment, and self identified measures of success. Second, they did completion of a pile sorting task, and that was also associated with collection of relevant demographic data. So, for this pile sorting task, an interviewer would hand participants a uniformly predetermined pile of cards, and they would ask you to sort the cards into four categories: high, medium, low, and no importance were the four categories. And then, second, you had to sort the individual cards within each category. So, what was the highest high priority item? And then, what was the lowest low priority item, for example? So, they wanted to see within each category where people ranked them. It's interesting because, like, without really even getting to the results, this kind of told me the most about the study to begin with. So, when they did the identification of items for a sorting task, the qualitative analysis of the semi structured interview identified 23 recurrent themes for pile sorting. So, they did the interviews, 23 themes, and then the researchers looked at the 23 themes and they wanted to add their own in. So they added these in. These were not even mentioned by the 16 participants. And the six classic measures that they added in by the research teams, this is research team, not patient driven, were negative urine drug screens, not getting arrested or violating probation, being tested for HIV or hepatitis C, decreasing how often I go to the hospital or the emergency room, decreasing how often I overdose, and having less physical pain. I don't know. What does that list sound like to you, Sonya?
Right, that's the checklist in my note template for treating opioid use disorder. Those are totally my metrics of success.
That's literally all the crap I care about, right? It's like, and like, so, like, all, like, right out of the gate, that told me the most about this article, and we'll get to the next part of it. But literally, that was like mind blowing to me. That like everything that I consider a success, they didn't even register as a measure of success to these patients.
Yeah, that's a little sad, but it's totally true.
So, second, they did the completion of a pile sorting task. And so, in terms of frequency, things that were placed in the high importance category were stable housing, no opioid use, no physical dependence, being happy, feeling neat and clean, optimism, self worth, and no arrest. Medium importance was sense of community, attending group, and handling frustrations. Low importance was decreasing ED/hospital visits, decreasing overdose, having a sense of community, abstinence from all drugs, less pain, and no importance was being tested for hepatitis C and HIV, decreasing overdose, decreasing ED and hospital visits, and decreasing use of opioids. They did this non-metric multidimensional scaling where they basically mapped inter-item similarity for frequency and analysis. And what they identified were like these three clusters of areas where people put their most emphasis. And the primary cluster really broke down to emotional well-being, decreased drug use, and human functioning. So they want to be basically patients want to be happy, healthy, and they want to be like a functional human being. That's what they desire out of treatment. And the number one item in the cluster was stable housing. Other things in the primary cluster were optimism, happiness, sense of self worth, no opioid use, no opioid dependence, being neat and clean. The secondary cluster was buprenorphine group, so attending group, being honest in group, contributing to group, so almost like a sense of community. So number one was like global emotional well-being. Number two was their community. And then the tertiary cluster was basically traditional measures of success, like taking the medicine as prescribed, absence, no other substance use. So like the patients in these programs, they want to be emotionally well. They want to feel that they have a functional life, and they want a community that they're a part of and they feel like they can relate to. So what do I do now in this same case? I do issue the patient a 1 week bridge script for his next appointment. At the subsequent visit, I will commend them for either securing the job or for just trying to get out there and do something, right? Just to try to get out and interview for a job that's hard. Oftentimes they have to disclose kind of criminal history or misdemeanors. And I think it's very humbling for someone to put themselves out there like this. So I think it's a big thing for them to do. And I'm proud of them for trying. Looking ahead, I'll inquire about the patient's recovery goals and discuss like what would a plan look like moving forward where we could actually kind of tailor our schedule to align with what you want to get out of the program. And oftentimes it's a much more productive conversation, and I've had pretty good success with that.
Well, and that's great. It's kind of embarrassing to admit this, but I look back on my previous buprenorphine work, and I had worked with, a recovery support organization, a community organization in the past, and they had sort of a structured program. You will do this, this, and this. You will go to this group, or you will do whatever our program is if you want your buprenorphine. And you have to prioritize our program above all else, including job, family. And as the years have gone on, I've become less and less, prescriptive, telling people what to do. We spend a lot of time now, the recovery support people I work with now really work to ask the patient what their goals are and how can we help them get there. We don't kind of tell anybody what to do. We just try to help them meet the goals they want. And it's this article and then, talking about the issues surrounding it totally changed my practice.
Yeah. And that's what I thought was kind of cool. Small qualitative article, but really changed my perspective. Like it wasn't practice changing, but it was perspective changing. And that really has kind of helped me with patients.
Well, right. And it's not the data in this article. It's just interviews with 16 patients, and they aren't even necessarily very similar to the patients that we see, but it just was a explosion of, perspective change to talk about it and think about it.
Well, thank you for listening to the Addiction Medicine Journal Club. We want to know which articles have changed your practice. Send them to us on Instagram, Facebook, Threads, YouTube, Spotify, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Aaron McHugh. CME support from My Cares. Produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being a part of the conversation and have a great day.